All right, our next presenter is Dr. Claudine Isaacs from Georgetown University. She will be presenting GS503, evaluation of anti-PD-1 cemiplimab plus anti-LAG-3 Regen 3767 in early-stage high-risk HER2-negative breast cancer, results from the neoadjuvant I-SPY2 trial.
I'd like to thank the organizing committee and the session chairs for giving me the opportunity to present on behalf of the I-SPY2 trial consortium the results of cemiplimab plus Regeneron 3767 and anti-LAG-3 in combination with neoadjuvant chemotherapy in high-risk early-stage HER2-negative breast cancer. Here are my disclosures. Regeneron 3767, also known as fianlimab, is a fully humanized, high-affinity monoclonal antibody that binds to and antagonizes the lymphocyte activation gene LAG-3. LAG-3 is a cell surface molecule expressed on immune cells that functions by binding to MHC class II, leading to inhibition of T-cell proliferation and activation. It is often co-expressed with PD-1. Cemiplimab is an anti-PD-1 antibody that is FDA approved for the treatment of a number of malignancies. The role of pembrolizumab, an anti-PD-1, is now well established as neoadjuvant therapy in triple-negative breast cancer. Preclinical data indicate a synergistic interaction with dual checkpoint inhibitor therapy with an anti-PD-1 and an anti-LAG-3. The combination of an anti-PD-1 and anti-LAG-3 antibody therapy has been studied in previously untreated advanced melanoma and shown to be a very active combination, most recently resulting in a significant prolongation of progression-free survival compared with anti-PD-1 antibody therapy alone in a randomized phase 2/3 trial. I-SPY2 is an ongoing, open-label, multi-center, adaptively randomized phase 2 neoadjuvant platform trial testing multiple investigational arms versus a shared control. At the time this arm enrolled, the shared control was weekly paclitaxel alone without immunotherapy for 12 weeks. All arms then received AC for 4 cycles. Eligibility criteria includes having a tumor that is at least 2.5 centimeters, and if hormone receptor positive, the tumor must be MammaPrint high risk. The cemiplimab, Regeneron 3767, and paclitaxel arm, which I'll refer to going forward as semi-LAG-3, enrolled only those with HER2-negative tumors. The primary endpoint of the trial is PCR. Semi-LAG-3 was studied and eligible for graduation in all three HER2-negative signatures, all HER2-negative, triple-negative, and hormone receptor positive HER2-negative. Agents graduate in I-SPY2 if there is at least an 85% predicted probability of success in a 300-patient phase 3 neoadjuvant trial with PCR as a primary endpoint. Patients are assessed for graduation in each pre-specified biomarker signature. The immunotherapy antibodies were given every 3 weeks for 4 cycles during weekly paclitaxel therapy. A total of 76 patients received treatment in the semi-LAG-3 arm. The total number of controls in the I-SPY2 trial is 350. As you can see, patient characteristics were similar between the two arms. Median age was 47, and about 55% of patients had hormone receptor positive disease, and about 42% had clinically node-positive disease. Shown here are the results of the primary efficacy analysis. The curves above show the probability distribution curves for PCR. The midpoint of the curve is the estimated PCR rate. Dual checkpoint inhibition with semi-LAG-3 increased estimated PCR rates compared to the control arm in all 3 signatures. In the HER2-negative group, overall the estimated PCR rate increased from 21% in the control to 44% with semi-LAG-3. In the triple-negative subset, the estimated PCR increased from 29% to 53%, and in the hormone receptor positive group, PCR increased from 14% to 36%. The predicted probability of success with semi-LAG-3 in a phase 3 trial relative to control was between 91 and 95% in all 3 biomarker signatures. As this exceeded our graduation threshold of 85%, this combination graduated in all 3 groups. Shown here are the results, Response was also assessed by residual cancer burden, or RCB. RCB 0 and 1 is prognostic for improved relapse-free survival compared with RCB 2 and 3. As you can see on the left, the addition of semi-LAG-3 to paclitaxel resulted in an increase in the percent of patients with RCB 0 and 1 in all patients with HER2-negative disease. On the right, you can see that RCB 0/1 is increased in both triple-negative, where it went from 48% to 70% with the addition of semi-LAG-3, and in those with hormone receptor-positive disease, where RCB 0/1 doubled from 29% to 60%. This table shows non-immune-related treatment emergent adverse events that were at least 10% different between the semi-LAG-3 arm compared to control. You can see that there were very few grade 3 or greater AEs with this combination. There were some modest differences in incidence of toxicities with semi-LAG-3, such as fatigue, headache, diarrhea, and elevated ALT, but the main issues we saw were immune events, which I will show you momentarily. Here are the immune-related AEs seen with semi-LAG-3. Just over half of the patients experienced an IRAE. Hypothyroidism was the most common, occurring in 32%. Importantly, adrenal insufficiency was reported in 21% of the patients. And of note, type 1 diabetes occurred in 3 patients. We looked at the timing of onset for each of the IRAEs. The majority occurred during the AC phase or beyond, including most of the cases of adrenal insufficiencies. And interestingly, 2 of the 3 cases of type 1 diabetes occurred more than 3 months after completing all neoadjuvant chemotherapy. This pattern of late onset IRAE is similar to our prior I-SPY 2 experience with other immune targeting agents. The I-SPY biomarker group, using gene expression, created a new set of classifiers or response predictive subtypes, including developing an immune signature to predict response to immuno-oncology drugs. These results were published in Cancer Cell this past June. Based on this test, in collaboration with Agendia, we developed a diagnostic test known as Imprint, which is now in use in I-SPY 2.2. In this graphic, you can see that in the semi-LAG-3 arm, the immune positive signature was seen in 17 of 36, or 47% of those with triple negative disease, and in 11 of 40, or 28% of those with hormone receptor positive HER2 negative disease. We looked at past CR rates in the triple negative and hormone receptor positive subsites by immune signature. While the numbers are small, we noted some interesting findings. As depicted on the graphic on the left, in patients with triple-negative breast cancer, those with the immune-positive signature had over a doubling in the observed PCR rate, going from 35% in control to 82% with semi-LAG-3. While there was a modest improved rate of PCR in the immune-negative signature, the PCR rate overall was much lower. In patients with hormone receptor-positive disease and the immune-positive subtype, those receiving semi-LAG-3 achieved a near tripling in the PCR rate, going from 33% in the control to 91%, or 10 out of the 11 patients in this subset achieving a PCR. Interestingly, the PCR rate also numerically increased in the immune-negative group, going from 8% to 28%. The findings from the I-SPY 2 arm evaluating cemiplimab alone plus paclitaxel were presented at the poster spotlight session on Thursday morning by Dr. Stringer-Rieser. This trial is not designed to compare across experimental arms, so we need to exercise caution interpreting the data presented on this slide. Nonetheless, going ahead with this, in the overall population compared to semi alone seen on the left, semi-LAG-3 resulted in a greater improvement in estimated PCR compared with the control group of paclitaxel alone. While not shown here, this differential benefit was more marked in the hormone receptor positive subset. When one looks just at the immune positive signature, however, the rate of RCB 0/1 were similarly increased in the semi-alone and the semi-LAG-3 arm compared with control, and both are clearly highly effective therapies. In conclusion, Dual checkpoint inhibition with cemiplimab and Regeneron 3767 was a highly effective therapy and graduated in all 3 HER2-negative subsets. The new imprint signature identified those deriving the greatest benefit from checkpoint inhibitor therapy. In our experience, however, there was a high rate of both adrenal insufficiency and type 1 diabetes, toxicities which impact quality of life. This rate was not observed in the melanoma trials. Given the excellent clinical activity of this combination across all HER2-negative subtypes, we are planning to evaluate the safety profile of lower dosing of Regeneron 3767 in combination with cemiplimab and paclitaxel. We would like to thank the remarkable patients and their families, our amazing advocates, and all of the I-SPY2 investigator staff and DSMB for supporting this trial. We would also like to thank our funding partners, those that provide investigational agents and biomarker platforms, and the study sponsor, Quantum Leap. I'd like to thank you for your attention.
Thank you, Dr. Isaacs, for presenting this rather complicated study in such an elegant and easily understandable form. Dr. Isaacs is with us virtually, and she's able to hear us and the microphones. I'm trying to see. Okay, we have an online question. Can you comment on these results in the context of the I-SPY2 pembrolizumab Taxol results presented by Rita Nanda, please?
Yes, so with this combination, we saw similar rates of PCR overall, or estimated PCR. And again, realizing that this is a small trial and the arms are not intended to be compared across this trial. We did see the highest rate of estimated path CR in our hormone receptor positive group with this particular combination. I think understandably, as we looked at the toxicity, we were certainly troubled by the toxicity with this arm, and we're very interested in investigating a lower dose of the Regeneron 3767 in combination with cemiplimab and paclitaxel to see whether we can maintain this excellent outcome, but mitigate the toxicities that we're seeing.
Thank you. Microphone 2, please.
Hi, David Rim from Yale Pathology. Did you assess the PD-L1 by IHC for this study?
We have not done that yet. As you're probably aware, this is a very rich biomarker study, so we have specimens available on all of the patients, in fact, multiple specimens available. So we will be looking at that, but we have not done that yet.
Thank you. Microphone 5, please.
New York, very nice presentation. As a real doctor, I worry how sick these patients got. The ones with adrenal insufficiency, hypophysitis, and the diabetes, as I understand it, can be very severe. How many were hospitalized? How many died?
There were no deaths, Dr. Vogel, and again, I'm honored to field a question from you. So there were no deaths on this arm. Obviously, adrenal insufficiency is a lifelong issue for many of these patients, so it's something that we are very concerned with. We have instituted in our current arms a much more focused and monitoring for adrenal insufficiency. We'd really like to see if we can detect it earlier, and we have some signs that we have some symptoms that develop earlier in these patients. So that's very important for us to look for. And obviously, we are concerned with the type 1 diabetes, which is why we're going to try and look at a lower dose of this agent and see whether we can mitigate some of those toxicities.
One last question that is related. Were the IO-related toxicities seen more often in the imprint high group?
We haven't fully analyzed that yet, but we will be looking at that. So thank you for that question. And we are really trying to look at all sorts of measures that can help us better ascertain when these IOs occur and whom they occur.
Thank you very much, Dr. Isaacs. Thank you.